If you're considering hiatal hernia surgery, I really want to talk to you about some aspects of it I think are very important. Now, I'll lead with the fact that I'm not a fan, but that doesn't mean I never think it's a good idea. So I'm not saying that. But, you know, if you were my very best friend or you are a family member of mine, this is what I'd be saying to you if you are contemplating the hiatal hernia surgery. Now, this is excluding the scenario of this is emergency surgery. Half your stomach's above your diaphragm. They're worried that the stomach could die due to torsion, life-threatening. You know, we're excluding ourselves from that. We're talking about the classic small to medium sliding hiatal hernia, which is what we deal with mostly here at the clinic. And there's a lot of issues that we see post-surgery, but this is not slanted. So I did lead with the fact that I'm not a fan, but I'm really doing an objective look here to give you sort of the best possible instruction and enlightenment and just data that you can have. So first of all, let's talk about the size of all of these things. So your esophagus, so that's the tube that connects your mouth to your stomach, its diameter is just shy of an inch. It's like 0.97 inches. So call it an inch, it's basically there. And then at the bottom of your esophagus, of course, it then joins to your stomach. So that joining, they call it the gastroesophageal junction. Gastro just means stomach. So it's just where the two join. That is anywhere from 4/10 of an inch to 8/10 of an inch wider. So when we're talking about a sliding hiatal hernia that's not in the oh my gosh, you know, a chunk of your stomach is above your diaphragm mode, that's what we're talking about. We're talking about that junction is pushing up above the diaphragm. So you're talking about 4/10 of an inch to 8/10 of an inch. So the whole increased opening is anywhere from 1.3 inches to 1.7 inches. So we went from just shy of an inch, 0.97, to a normal esophagus to 1.3 to 1.7 inches. So that's how much the opening has widened. And I think that's very key to know, because when we hear about, you know, that we have a hiatal hernia, it's like, oh my gosh, my stomach's in my chest. And, you know, I hear a lot of people describe it that way. And for the vast majority of people, it's not that dramatic. I'm not saying it's not a problem. It is. It's not normal. But we're not talking about this gaping hole in, you know, of your diaphragm with your, you know, this organ into your chest. It's when it gets to that point, there's no argument that surgery is the right thing to do. So I just wanted to sort of give some numbers to start. Now, we have what's called an anti-reflux barrier. The human body is very smart. It really knows that acid is a bad idea to have come up into your esophagus. So it has 3 different tissues that exist to prevent this from occurring. So one is at that base of the esophagus, just before it joins the stomach, there's what's called a sphincter or a valve. And there's one in the upper esophagus as well. And so the valve is simply this, you know, brilliant piece of equipment that senses that you have drank something or you're eating something, and so it opens, you know, it widens to allow that substance to come through, food or drink, and then it closes back off afterwards, keeping a nice pressure down, right? Because reflux is going the wrong direction. So it's that nice sort of pressure saying, okay, everything's in the stomach, needs to stay in the stomach and not come the reverse way. Now, above that lower esophageal sphincter, that valve I just described, we have the diaphragm. So the esophagus passes through the diaphragm and then turns into the stomach. So that lower sphincter is anatomically correctly below the diaphragm. But the diaphragm itself, right where that opening is, has this nice area of muscle called the crural diaphragm. And what's great about that is it's another redundancy to say, okay, the diaphragm moves as we breathe. So of course we're always breathing faster or slower, but we're always breathing. And then this sphincter of muscle, so it acts as another valve around the esophagus. It acts as another valve, as I said, to kind of keep that pressure down, right? Pressure down, not letting things flow back up. And then there's a ligament that attaches between your diaphragm and your esophagus. So that's lower down, below the diaphragm, that also keeps, pulling that diaphragm down and into the esophagus. So it's kind of an anchor. They call it a little sling. So it's on obviously each side, and it's sort of just again a nice little pull down. So keeping that pressure down. And so you've got these 3 anti-reflux barrier components that exist. Just wanted you to have the anatomy of it. Okay, so now let's jump into surgery. And one more thing. I looked into, because I'm confronted by the fact that we have thousands of patients we see, and I'm not saying we cure 100% of them, we do not. We have an 85% success rate, which I'm very proud of. And what does that mean? That means that people come in with symptoms and 85% of them say, my symptoms are either much improved or totally gone. They're happy with the change. So you so often hear, listen, the only way to fix this hiatal hernia is you've got to have surgery. You've got to have surgery. It's a mechanical issue. It's stretched. It's got to be closed back. And it's like, oh, okay, I've got that. But then we see some pretty serious cases who resolve to their satisfaction, meaning they don't have the acid reflux, they don't have the shortness of breath, they don't have the anxiety, they don't have the heart palpitations, they don't have the bloat and gas. All of those symptoms have resolved and they feel great. Now, they have learned what to do and what not to do. So I'm not saying they go back to the horrible diet if they were eating a horrible diet as before. I mean, you have to be smart about it. We got you here via you learning certain things about your body, what it likes, what it doesn't like. But we did get them there. So what does that mean? So I looked into it, and that lower sphincter can regain some function if you get to the root cause of why the pressure has been on it. This is without surgery. And also that crural diaphragm, that circle of muscle around the esophagus where the diaphragm opens to allow the esophagus to go through, that's above the esophageal sphincter, right? So again, the redundancy of both of them, and they're very close together to support that lack of reflux, that they've seen improvement, symptom improvement and partial reversal on imaging. So that was cool. So actually seeing that, that widened opening of that crural diaphragm improved on imaging. So because it's like I said to myself, there has to be functional change, because we see it all the time with patients. And if surgery was the only way, then we would have 0% success, and we don't. So I wanted to, focus on that up for a moment, just to give you some perspective. The body, after 40 years plus in practice, I can tell you the body loves to heal. When you take pressure off of it, meaning negative pressure, you're no longer preventing normal healing from occurring because you've removed obstacles. I talk about, obstacle removal, but you're removing these obstacles to your body's healing, and then it restores and it can heal. So it was good to see some documentation, because a lot of times medical literature, is very conventionally medically oriented, but there wasn't a lot, but there was definitely, data to support what we see here at the clinic, because we see it a lot. This is our specialty. Okay, let's jump into the surgery. So common is the Nissen fundoplication, which just means a folding, and then the TIF procedure. Those are quite common. And the Nissen, which is very common, so the failure rate is considered to be 15 to 30% over 5 to 10 years. The TIF is 25 to 40% symptom recurrence. So fairly high, getting up to 30%, getting up to 40%. So fairly high. And so then the question is, okay, why do they feel that it fails? One, of course, is, the surgeon didn't do as good a job as he or she could have. That was, of course, listed. So improper repair is what it's called. And then it was mentioning, well, the hiatal hernia recurs. It's like, okay, good. Why did it recur? And that's getting into, the thing that I talk about all the time, which is this increased intra-abdominal pressure, right? So you've got this pressure within the abdomen that's putting pressure on the stomach. The stomach is forced up, so all those valves are forced to open when they should be being able to clamp closed. It puts pressure on the diaphragm elevates, gets near the heart doesn't like it, you get heart palpitations. The diaphragm also kind of spasms a bit, so you get shortness of breath. That gives you anxiety. There's a whole cascade of things that I talk about a lot in a lot of other videos. But it's that increased intra-abdominal pressure, which was noted as a root cause of why the surgery is failing, because the hiatal hernia recurred. And I hear this a lot with patients who, the surgeon just says, well, it came undone, like it looked good when I did it, when you were unconscious, it looked good, but it came undone. And so one thing I just wanted to mention right now is that, again, if you were my best friend or a family member and you said, what should I do? The first things I would say, again, non-emergency surgery here, is I would address all of these root causes that would cause the surgery to fail. We're going going with the viewpoint that you have to have surgery for whatever reason. So to get to address the root causes so the surgery doesn't fail, not only is it great because it, makes the surgery more successful, that would seem to occur, but also you would go into surgery in much better shape because we're decreasing that intra-abdominal pressure that's putting so much pressure on your stomach and all these valves. But where's that pressure coming from? That pressure comes from inflammation, fatty liver, small intestinal bacterial overgrowth, dysbiosis, meaning the good bacteria in your colon have been offset by bad bacteria. So you've got this inflammatory profile, which is a terrible way to go into surgery, versus handling all that, which would give you a much better chance of just, surgery. There's always risks associated with it. So if you went into the surgery more robustly healthy, obviously you're going to have a better outcome chance than if you didn't. And then, so what else came up was obesity, which is a common one because you've got that you've already, due to the obesity, you've got increased intra-abdominal pressure. And of course, with obesity is coming inflammation. So getting to the root cause of the inflammation, then we see patients lose weight and that, that belly weight, which is so highly inflammatory, not only is increasing pressure, but it's increasing your risk of a whole host of diseases. So we address that naturally. No, it's not the quick fix of, a week from now you've lost 20 pounds. This is a process, but it's a great process because you come out of it. So you're talking about several months. Okay, it probably took you decades, to get to this point. So I think it's a beautiful thing that the body heals within several months. It's pretty fast overall. The other thing that came up is that somebody has LPR, which is also known as silent reflux. I recently did a video about that. But so that is somebody having these symptoms, but it's not due to acid. In other words, the surgery is being done when the problem really isn't due to acid. You do have issues with the valves, but it's more that upper esophagus. And of course, these surgeries are not addressing that. So you've got a bile reflux, you've got something called pepsin, which is a hormone, it is a hormone made in the stomach gastrin is the hormone. Pepsin is the enzyme. I got it. And so the pepsin comes up from the stomach and then gets activated with the acid, a little bit of acid in the throat due to whatever you're eating or drinking, and you get symptoms up here. So, and bile can do the same thing, and bile is very, very caustic. Acid is caustic on the esophagus, but so is bile. So the LPR, or the silent reflux, is if that's the root cause of the person's problems and their symptoms and that's missed, then they're going to get surgery and nothing's going to change. And I've heard that a lot from patients as well, post-surgery, which of course is very distressful. Then we also have gastroparesis. So these are all reasons why the surgery is not successful. So gastroparesis is slow movement within the stomach, which it can also affect motility in the esophagus. So it's all about motility. You know, you swallow, you shouldn't feel like something's stuck in your throat. You eat, you shouldn't bloat and just have it sit there and be constipated. All of that are motility issues. And that's a big one. So if you have these motility issues, then post-surgery, you're going to get that increased intra-abdominal pressure again. And especially if it's slow motility in the stomach, all of a sudden, you know, back you go to the pressure on those valves, and then the surgery fails because that pressure can really build up. Okay, so what do we do about this? Specifically these motility issues, but honestly, it really is the embodiment of our program. So all of the factors, all of the root causes that I looked up, I was like, yeah, we do that, we do that, we do that. So let's review them. You've got the vagus nerve, which is your longest cranial nerve, and it's very intimately associated with how your gut operates. And it's a nerve that because nerves sort of tell organs and areas of your body to work properly. So you can get a loss of vagal tone, it's called, and then these sphincters, these valves don't work as well, and motility doesn't work as well. So when it comes to vagal nerve function, it's something we test for and something we work with our patients quite extensively if that's a component for them. So all of these things I'm going to mention, you know, it doesn't mean you have every single one of them. It's like, what's a component for you? Is it or isn't it? But if vagal nerve loss of tone is present, it's a very natural treatment. So there's nothing, unless you really have damage to your neck, and then it gets a little bit more involved, but generally speaking, it's a completely natural type of treatment that's involved. So posture is key, because, you know, we're talking about not just the nerves going to the stomach and the nerves going to the diaphragm, but, you know, if you're somebody who's really hunched over and you don't exercise at all, if your neck is, you know, if you really lead with your neck, which puts stress on the vagus nerve, if you've, you know, had some accidents in your life and you're really stiff in your neck and you're stiff in your middle back, all of these things, they need to be addressed to restore normal nerve function and to get your diaphragm moving the way it should. You know, some people, you ask them to breathe in. Now, I just did a belly breath. You probably saw a little in my shoulders, but when people they can't belly breathe, you know, they breathe with their shoulders, so they're shallow breathers. That's going to affect all of these areas. I mentioned exercise. You've got to be mobile. The body needs to be mobilized in order for things to move well through the gut, not to mention hormone balance, etc. So posture is a big one. Now, certain vitamins and minerals, interestingly, magnesium, B12, and zinc being the key nutrients to help with motility of the gut. And guess what? PPIs completely destroy your ability to absorb what I just said. So in addition to calcium. So that's problematic with PPIs, but magnesium and B12 are very commonly deficient in our country. So addressing that. There are things called prokinetics, so kinetic motion. Ginger, as an example, is a natural prokinetic. There are drugs too, but drugs are harsher, they have side effects. So here at the clinic, we like to stick with the natural ones. There are several. Ginger, as I mentioned, is one. Melatonin is one. Because a lot of times when you're trying to get motion going, you want to do it between meals, you want to do it when you're asleep. And so a lot of times the prokinetics are dosed at times when you're not actively eating. Overall inflammation is another key root cause for this problem, because when you're inflamed, your immune system is not working the way it should. Certainly the gut bacteria will get imbalanced, and all of this leads to just this inflammatory, on fire profile that creates, again, that increased intra-abdominal pressure. It all kind of comes back to these pressure differentials. So interestingly, I mentioned the melatonin. Chewing your food is as a lifestyle basic, but also normalizing liver, and if you have a fatty liver, so normalizing that, which can be normalizing bile flow. All of these beautiful parts of the gastrointestinal tract, they all need to be flowing and moving well and not backing up. Low thyroid, interestingly enough, it can affect the sphincter strength and tone. So you've got the vagus and then you've got low thyroid. So it's amazing the way so many parts of the body are interrelated. And so we always check that. Diabetes, stress. I mean, stress affects everything, but it very much affects your vagus nerve, and it very much affects your gut health. So we know that to be the case. So again, we're assessing all of these things to see. And some people say, I get some stress. I don't consider myself a stressed person. Okay, so that's not a big one for you. That's what we're assessing. Diet, okay, big, as far as not only addressing the quality of your diet and real food that's being ingested, but then do you have any food sensitivities? Because you could be eating a really clean diet, but if you happen to be ingesting something you're really sensitive to, then that's going to put pressure on your digestive tract, which we don't need. Finally, I know this is a long list. SIBO, small intestinal bacterial overgrowth, creates its own pressure because you've got all this bacteria in the upper small intestine being produced. It's overwhelming your immune system, it's creating inflammation, it's increasing intra-abdominal pressure. So I know that was a long list, but my point here, once again, is if you're thinking about surgery and you're really wedded to it for whatever reason, I think, again, my recommendation to you, who I'm addressing as my very best friend here, would be to say, let's get you in the very best shape possible, not just for generally speaking, you're in better shape, you're just going to sustain surgery with an improved outcome, but the very reason you're getting the surgery, that's been addressed, and now that mechanical change that the surgery can create has a very good chance of success, unlike what I see quite a bit with patients, which is they're not happy. Now granted, I'm seeing the people who are not happy. I do realize that. And on my channel, I hear from people who are perfectly happy. But a lot of times these are people who just had it a few months ago, the surgery. And so then I wonder, I'm like, well, I know there's this window of 5 to 10 years. I wonder if they're still going to be happy 5 to 10 years from now. And one thing I know to be true is all the things that I just reviewed as far as root causes that have to be addressed, your surgeon isn't telling you to do any of those things. Absolutely not. I know that to be true. And that, I think, is unfortunate, because let's say you had a perfectly successful surgery, you don't have any reflux anymore, but you still have some of these things kind of marinating in your body. It's causing other things. It's moving you toward diabetes, it's moving you toward heart disease, it's moving you toward cancer, it's moving you toward cognitive decline. It's just the nature of what we know these things to do. So it's a good idea regardless. So I hope this made sense. I really wanted to address this because I'm asked this a lot, and that's the order in which I would recommend doing things in, you know, again, if it was one of my clinicians here at the clinic, that's what we would do. You know, that's what we'd absolutely recommend, as long as, again, it's not an emergency moment. So if you enjoyed the information in this video, I would love to have you give it a thumbs up, subscribe to the channel, because we're really trying to increase our subscribers so that more people get this information and they learn what their options are, and they can regain their health, which is so important to us. So I do appreciate you. I answer all my comments, and we'll talk soon.